I want to thank all of our speakers that are up here for participating today. I think it made a really nice, integrative panel of talks. I think that we all learned so much from very different perspectives. So if we can just take a moment, I want to just thank them for coming and joining in this. And we have a couple questions that were directed to specific people, so I'm going to start with those. This one was for Stacy. There was a question about how you were able to handle going to school and getting a job and getting married and the things that you did accomplish in your life in the context of the experience of BPD, your anxieties and your insecurities. Did you feel that there was something that pulled you through doing all that?
Yeah, the desire to get out of Arkansas. I mean, it's really that simple. It's oh, I'm sorry. The iron fist of religion was so strong, and I was so, I was such an alien in that world that I knew that there was no place for me there. I had to get out and find where there was a place. And you know, the one thing that more than any other has saved me in life is books, literature. And I wanted to go to the place where there were the maximum number of books and writers. And it was always my goal to get to New York. You know, when I was a little kid, and I was watching, teenager, and I was watching Woody Allen movies and going, I just want to get to the place where they have apartments full of books. It was literature. It was books. I just had to get away from the Jesus and to where the books were. Like, it's that simple. You know, it wasn't easy. It was just that I didn't fit. There was no place for me there, so I had to go find the place where I fit.
Okay, thank you. Dr. Swenson, there's a question about how do the peer-to-peer DBT skills training models work? Do you need to have a peer center, or can you have other modalities in which they're implemented? And are the facilitators trained graduates of skills training groups, or is it, can you learn some other way?
I've known a number of different, I guess, groups or situations where people who've been through DBT skills have then grouped together and started to form peer-to-peer support groups, peer-to-peer teaching skills, reviewing skills. Sometimes it's because there's just not enough resources in the community to keep it going with professionals. Sometimes people just would prefer to try it without professionals. There's one that's worked really well for about 12 or 13 years where I am in Western Massachusetts, where we sort of developed a model where there's a nurse who is a DBT skilled person and very enthusiastic about them. And she teams up with a team of people from the Department of Mental Health, patients in our area that have been through DBT. And if they want to, after they've been through at least a year, they can connect with her and then join up and become a co-teacher with her. And then they go teach the skills to other populations, other situations. They go to hospitals, they go to clubhouses, they go to residential settings, and they teach an 8 or 9 week skills package with a co-teaching between a professional and a peer. And it's worked really well, and so she has a whole team that she considers the peer teaching consultation team. And they work together. So over the years, she's gone through doing that with maybe 20 different people. And what's been amazing is to see that it's the next step in recovery for the ones who do the teaching. And you can see that it's valuable for the ones that receive the teaching, but really the ones who obviously benefit is the ones who do the teaching. They sometimes are still going in and out of a hospital now and then, but that doesn't disqualify them. They just have to show up. And they get ready, and they teach part of it, and she teaches part of it, and then week by week or month by month, she gives over more to each of them, and she takes a background role. And 3 of those people have now gotten paying jobs in our area as skills teachers. So it's been a really successful model, but that's just one model. I think there's probably other ways to do it.
Yeah. So it sounds, from one of the questions is asking something, I'm going to kind of blend a couple of them together, but it sounds like each of you mentioned a little bit about how therapist factors play a role in how efficacious the therapy is that's being implemented. I think it even started off this morning with you have to like the therapy, if I'm remembering what you said correctly, Suzanne, that you have to like the therapy you're doing in order to be efficacious with your patients. So there are a couple questions about that, about wondering how much do you each think that the therapist factors, what qualities in the therapist do you think are facilitating each form of treatment? What do you think therapists need to have in order to successfully implement that form of treatment?
Can anybody lead off?
Anyone?
Oh, okay.
Go ahead.
Lois had
Well,
something.
could I say that there's a tremendous amount of evidence for this, not just in borderline personality disorder, but across the field. So there's a guy named Wampold who took huge data sets, and instead of nesting them by cognitive behavioral or psychodynamic or this or that, he nested them by therapists. And it becomes very clear that the therapist effect is more powerful than the cognitive behavioral or psychodynamic or whatever. And maybe the interaction is very powerful, but clearly there are therapist effects. There's no doubt about it. Now the next question, which I'm going to leave for my learned colleagues, is, so what are the best therapist qualities?
How about Lois? Because you actually talked about that in one of your.
Yeah, you know, I think that what I can say about all the treatments, because I've participated in a number of different treatments for BPD, is that I think number one, it takes openness and a balance of clarity with humility. You have to be very clear about what you're doing, why you're doing it, whether or not it's working, and have enough openness and humility to know when it's not working, you know, because I think that with the rise of evidence-based treatments, people do become more rigid about what they do. And even before evidence-based treatments in psychoanalysis, there was a lot of rigidity at times. And there's a reason for it. It's not like just a kind of thing to devalue, but in the face of some painful realities about people's lives, you have to brace yourself with something. And working with these patients, even though it's really rewarding and successful at times, it's very intense and it creates burnout, whether it's in the family or in the therapist. And I think it's something that you have to be able to face and recognize and have some radical acceptance over, and be able to kind of regulate yourself around and mentalize around and understand the relationship around. So I think there's something to be learned from all these treatments. And, you know, I think that that is really what matters more than, you know, a specific thing. But what I can say about mentalization-based treatment is that people who don't like not knowing aren't going to be good at it. And, like, if you can't say, I don't know, or I made a mistake, or I might have caused you a problem, you're not going to be a good, I think, therapist with these patients in general. But I think in mentalizing treatment, you really have to start with being able to say that.
I would just pick up right there. I was thinking also, before you said humility, I thought persistence is one, humility is one, the qualities. But another thing that's hard to capture, I think, is that a therapist has to be alive. And I think what brings you alive as a therapist is that you do things that actually fit you, that actually work for you. So that when you say you have to be comfortable with not knowing, now, people who aren't that comfortable with not knowing might be fabulous therapists when they're doing something else. But if you do mentalization, if you're not comfortable with not knowing, you're in the wrong model. I mean, and you have to sort of bridge that gap somehow. But I find, you know, figuring out what works, and it's different for different patients. So it's very complex, because what I do for some patients, I do different things than for other patients. I have to find what works for me, which then also works for them, and works for both of us. And the one other quality is, I think that if you want your patient to be committed to changing and care about changing, If you don't deeply care about it, it won't happen. It'll just be, you can't just deliver one of these models as if it's a technique. I think you have to feel like, I'm doing this because the world depends on it, because this patient depends on it, this family depends on it, because this is going to work, and I'll change gears if I need to. And I think it's modeled by all of the best teachers in every model.
And I think that just on the other hand, in terms of as we have more evidence-based practices and rigidity, in some ways, on the other hand, I think they've allowed us to be more flexible. And I think your word humility is so perfect, because one of the things that I appreciate is that ability to say, you know, what I'm doing, how I'm working with you may not be working, and here's all these other things that can help. And if I don't know how to do it, can I get you to the right person? So I think this other issue of being curious, being generous with the, with the idea that there are more than one way to help you. And I've also been very big with my patients on this kind of whole notion of informed consent. Here's the model I'm using. I like doing this model. I've helped people with it. It may not work for you. Here's these other models. Here's what we know about them. Here's who do them. And letting, you know, people are grown-ups. I mean, except for the kids. But, you know, I mean, they can pick. And I think this is why also access to multiple treatments is crucial from a public health perspective. So.
And I just want to say one thing just to add to what you just said is that I think that like with families and the family guidelines, you have to let yourself be heard. You know, that is an important part of the humility part, is that, you know, to be able to have an open dialogue. I think that when somebody's in, like, whether you call it emotion mind or like affectively focused rather than cognitively focused, I think it's very tempting for a therapist or a family member to get incredibly rational and authoritative. And I think that sometimes contributes to that rigidity, but it's like an adaptation, just like the symptoms of BPD. Right. And just being aware and mentalizing what you're doing and why you're doing it, I think is like a capacity that is going to help a therapist of any modality as well.
I have an answer to that one as the patient, if I may.
Yes.
The single biggest thing that helped me when I was going through both DBT and with the therapist that I talked about, Dr. Nichols, was when they were willing to share something about themselves with me. That's a huge thing. The fact that Steve Nichols gave me a book of his off his shelf and let me keep it, it was an object that I had of his, and I could touch it. And I remember that when my DBT therapist one day finally told me something about herself. She told me her cat's name. Her cat's name was Pandora. I'll remember it for the rest of my life. And the fact that she let me see that she was a human being and not just someone who knew a lot more than I did and was going to teach me how to function in the world was enormous for me.
I love that.
Yeah, it's true. Pandora the cat. I'll always remember.
No.
Thank you.
You know, in dialect behavior therapy, one of the assumptions we make about therapy is that it is a real relationship, and just like you talked about real relationships in the moment, I think all good therapies know, you mentioned real relationships. It's not like a pretend relationship to represent relationships. Yeah. I mean, so I think that for me, I think this whole notion of appreciating that and not being afraid to, if your limits are to disclose things, you disclose them. You know, different therapists have different things they're willing to disclose, but for God's sake, I mean, we're just humans sitting in a room, and hopefully one of us in this moment is more ordered than the other and are helping pull the other one there.
Well, it's also a way of saying, I'm not afraid of you. You don't have this incurable thing that's so scary that I'm afraid that if I tell you anything about me, you'll stalk me.
Yeah.
Seriously. And I didn't. I didn't.
And even if you did, you would deal with it. Cut it out.
No, Pandora the cat, I kept it to myself.
I think I hear there's a theme that the relationship is key. Whether it's how we're thinking about the relationships, the relationship with the therapist, how the therapist relates to the therapy. It's all about relationships in some way. So,
two quick comments
Yes.
from the parental end. We've had, and I was struck by when Lois was showing the eyes and how well people with borderline personality sort of did in that. But actually, I was not surprised. They're tremendously sensitive. So they're going to walk in a room and sit next to someone they're going to get something, and who knows what they're getting that from. So sometimes it's a matter of fit. We've had parents in our group, different parents, go to the same therapist. One, it was revelatory, changed life. The other one didn't work at all. So the fit, and there's maybe an X factor there. That the same way the eyes look like eyes, but the X factor, that sensitivity. And you
Right.
want to mention?
But I just want to mention about HIPAA, because a lot of our family members don't get told anything. And it's very frustrating, because if they're in a situation where their loved one is not going to sign the HIPAA form, they don't get any information. So they actually asked us to ask clinicians to include the family in some way and to let them tell what they see is going on in the home, because they don't often get that other side. You know?
That's a very good point. Thank you. We have a lot of questions. As you can see, I'm holding them in my hand, and they're all pretty much asking the same thing, and it's across therapeutic approaches. So I'm going to, again, put this to the whole panel. There are a lot of questions about how do you find someone who's well-trained or certified or knows how to do this therapy? How do you tell that a DBT provider is going to be a good DBT provider versus a not-so-good one? How do you know if they're certified, what kind of education do they need to have to make sure that they're good treatment providers? And I'd anticipate this is a slightly more complex question to answer than that, but do people on the panel have any recommendations for people looking for good treatment providers?
I can speak to I can't speak obviously to mentalization and transference focus, but I can certainly speak to the state of the state in terms of dialectical behavior therapy. I've been working with Marcia on certification of clinicians, and we are about to go ahead and launch the Linehan Board of certification program. So that's going online. It was supposed to go on May 1st, but if any of you have ever worked with Marcia, we hope to have it before June 1st. But I think this is an important issue because, you're working with, from a public health perspective, you're working with a common severe mental illness in the terms of its cost of suffering on individuals and families, and it's like schizophrenia. It's about 2% of the population. It's quite a bit of people are affected by it, and these treatments that we've discussed are not, as Lois pointed out, they may have some very basic, if you step back and understand the core of the theories behind them and the way you're operating, but they're not simple to do.
No.
And so our patients do suffer from people hanging up shingles saying they know how to do things. And I know that's why in dialectical behavior therapy anyways, it's become very important that consumers, family members, know whether this person has some chance of fidelity in the model. So that's why we've been doing that. The other thing that you do short of that is, and I know Charlie did this way back even in Massachusetts, with at least know what components they're doing. In Minnesota, we had a legislative mandate that our MA has to pay differentially for DBT, so we pay quite a bit more for individual therapy and skills groups so that it covers the cost of consultation team and phone calls between sessions. And so because certification wasn't available at this national way at the time, we had to develop testing teams based on their programmatic. So there are ways, I'm sure, with your treatments as well, that you can educate parents and family members and patients about what to look for.
I'll just say something about this. I think that, DBT is replete with a lot of technical kind of aspects and skills that I think are really ripe for doing certification and adherence. And I think it's important that they do that in the kind of research framework they do. But I think that there's an argument that there's another side to it, is that adherence is in everything, and outcome is important too. Yes. And given this literature on functional problems, even when people symptomatically remit, I think clinicians of any brand need to really think about, is this treatment helping this person reach their goal? I think that's the gold standard of whether or not a treatment works, is if this person can have a meaningful life, and that matters far more than what the technique is and the technical implications. So, you know, what I would say about MBT is we are in a process of just trying to proliferate it before we can kind of do this more refined thing about it. But I do think that all the treatments really do need to focus on function as a primary outcome of whether or not it's working.
Could I just add, we run what's called the Borderline Resource Center, and you can go online and you can contact us and we will try to help you find somebody in your area. The problem is it's a very sad thing. We get all kinds of requests from all over, Alaska, Hawaii, you know, and places we don't know. And so one of the major problems is not who's been trained in specialized treatments, but just who in a local community can help at all.
Or is even willing.
Or even willing, yes. It's a serious problem.
Nichols was.
But to oversimplify, when somebody asks me if they live in the Boston area, I tell them to call Lois, okay? In other words, anybody I know in a medical center that has some academic interest in and savvy about the disorder, I tell them but there's many places where that's not true, and that's where it becomes extremely difficult.
I get this question a lot. I get readers writing and saying, where do I go, where do I look, and who do I turn to, and who's doing this in my area, and I try to sort of keep a list to give to people of the people that I know who are doing DBT, and obviously that's all I can speak to because that's what I did, so I'm really happy that I have the opportunity to learn who's offering other kinds of treatment. But I always tell people that as far as DBT goes, to try to find someone who's doing actual strict by-the-book Linehan DBT, because I know that I hear people say that they have gone to therapists who are doing some DBT. You know, they would teach them some skills here and there, but for me it was very much about memorization and practice, and going to skills training group and having homework, and having to come back with your diary card and with your homework done and say, I did this step and this step and this step, because when you're dealing with that kind of emotional dysregulation, you have to depend on memorization, I think, to a certain degree. If you're just, in colossal emotional overwhelm and you are trying to sort of use these skills that somebody kind of taught you, it doesn't work. You really have to, I love the acronyms, bless Marcia and her acronyms, because I can go down and be like, describe, express, assert, reinforce, I needed that, and I still do it.
Thank you. Well, I'm going to put out one more question that I think might take a looking forward stance, maybe as we think about the next 10 years, what we might be talking about 10 years from now. There has been a theme in the talks today. This person is talking about how social functioning and functional impairment and functional recovery is certainly a theme across them and a focus. And the person says, Dr. Clarkin said, if vocational impairment is the main reason that BPD patients fail to attain or maintain symptomatic and social functioning, how do you think that we might, as treaters, work to best target this problem? Are there certain work environments? Are there other certain factors that we should be looking for to move forward and improve the overall social functioning, work functioning, and other impairment that remains for patients?
I'll take a crack at it from any point of view. I'll go back to my comment that what changes is what you target. And I think that we've, since Linehan began the development of her treatment, what's been targeted relentlessly and in research has been the problematic behaviors and the high risk and the getting a commitment from somebody and getting people on board. And now there's some degree of targeting of post-traumatic stress disorder, anxiety disorders. There's been very little targeting of vocational success in DBT. Cedar Coons, actually, who has presented in these meetings before, did a project in New Mexico DBT as an adjunct to vocational rehabilitation that was quite successful. And Kate Comtois in Seattle has tried to target getting people out of the system. And I think as soon as you turn these are great treatment models and they have flexibility. If you really have somebody serious, start asking the question and looking at the outcomes and get an outcome-oriented answer to how do we get people more successfully working and having intimate relationships that are more successful. I don't know what'll come of it. I mean, but I think we could have a lot of anecdotal answers, but I think the big answer is when's the field going to start actually taking that research seriously, at least in DBT? Yes. I don't think we're there yet.
Right. And just to add, I mean, if you step back and look at the field of behavioral health, in all other, particularly if you look at the severe mental illnesses, and you look at SAMHSA had started working on trying to roll out toolkits for teams working with severely mentally ill individuals, not with those with borderline personality disorder in the 2000s, but this issue of people getting to work and working at real jobs. Just because you have schizophrenia, it doesn't mean you should go sit in a workshop and stick widgets in an envelope. And I know again, because I work in this sort of public health setting in which my big job is to keep people, get them out of the system and keep them from going into hospitals, this issue of targeting your life needs things in it that are meaningful, and that sense of mastery is huge. Or even like this morning, we were talking about sex, remember?
Yeah.
I mean, no, because and I thought, great, he's talking about sex too.
You brought it up first.
I did bring it up first. But, I mean, honest to God, I think Charlie's right. And even like what Lois is talking about, this idea of while the field needs to pay attention to research in it, we as individual clinicians need to have our eyes like a laser beam on what is going to make your life functional. And so I'm in a setting where I can follow someone over a number of years, and each thing that we do is as a clinician, I can be responsible to asking you what's going to make your life better and target it. Yeah. But I agree with Charlie, we need to study it, and we need to make it more obvious to people.
Could I add to Charlie's point? I think it's very clear that if you don't focus on something, it probably won't change.
Absolutely.
And so I think the field's now faced with at what point in the treatment can you focus on such things as work? And then B, how do you do that, and what are the steps? And I think that within the next 5 years, I think the field will be at the point of doing that. What we're trying to do, I think, is a lot like what Lois and John Gunderson do, because I was talking to John about this week. We're building it into the treatment contract. So right at the beginning, we're negotiating with people, not demanding, but we're negotiating with people how in this treatment are you going to get back to work? Volunteer, partial, whatever. And by the way, I'll add to that, and in this job market, it's not so easy for anybody to get a job. But for us, it isn't just getting a job, it's part of identity. So what is your identity? Who are you?
Absolutely.
I don't know about you, but I define a lot of myself by what I do in my work and what it means to me. And so it's trying to gear people along that path that has a meaningful connection to other people in many ways.
Yeah, I'll just add to that, just as you alluded to, in general psychiatric management, work is emphasized over love because the core problem is interpersonal hypersensitivity. If you have interpersonal hypersensitivity and you have this identity disclarity, you have no direction, no structure, your likelihood of having disorganization in your relationships is high, whether it be BPD or not. That's why in college, it like explains college, your classes are like Tuesday and Friday, or, it's not like really kind of regimented. And so I think that to emphasize for BPD patients, we're actually very heavy-handed in the Gunderson program, which is like an intensive program, but we say, you got to stay out of a relationship until you can sort yourself out, because it's too stressful.
Yes.
Get a job so you can regulate yourself. I use my job to regulate myself, and when I don't have work, I get dysregulated sometimes. But that you really have to help someone build a life around which they can kind of manage their sensitivities. So,
I'm going to add one comment myself, if that's all right with the panel. I think that what you guys have all just been saying was that we know where the research needs to be done. We know what needs to still be focused on, and the research just needs to be implemented. And I think it started out as a joke kind of today about Germany has all the money and is throwing it at BPD, which is in fact true. There are other countries that are putting a lot of money and resources right now towards studying the phenomenology of BPD and understanding the underlying neurocircuitry and neuroendocrine responses. And that's something that everyone here in this auditorium right now has the potential of having an impact on. This is, BPD Awareness Month, and it's also, I believe, the Mental Health Awareness Month. And this is a perfect opportunity. I am going to make a plug right now. This is a perfect opportunity for everyone here that's invested in this area of diagnosis and potentially the research to contact their representatives and let them know that you would like to see your tax dollars put towards this research. These decisions are made at the National Institute of Health. The National Institute of Health in the US is predominantly what funds the research we're talking about today and that was displayed today. Some cases we're lucky that we don't have to rely on that, but that is. And so I think as attendees of this conference, we can think about that and what role our voice could have and helping direct research for the next 10 years simply by calling someone and letting them know we think this is important. So we are out of time, but I want to thank the panel again. You guys have been wonderful, and we're very appreciative.